I'm here today with Dr. Vicki Seltzer at the 51st Annual Clinical Meeting of the American College of Obstetricians and Gynecologists. Dr. Seltzer, a former president of our college, is here today to explain a little bit about herself and about her relationship with the college. Vicki, let me welcome you very much and thank you on behalf of the college for your willingness to come and share with us today.
Well, of course, it's my privilege.
Let's begin by, could you give me a little bit of a background about you, where you took your training and your academic career?
I grew up in New York and I went to NYU Medical School, and in fact Saturday was my 30th medical school reunion. So I graduated in 1973. I did my residency at NYU Bellevue and my fellowship at New York Medical College and then Memorial Sloan Kettering in New York. So basically my whole career has been in New York. My first job was the Associate Director of GYN Oncology at Albert Einstein Medical School, and I stayed there for 4 years, and then I had this great opportunity to run OBGYN at Queens General Hospital. I was less than 4 years out of my fellowship, and it was a terrific opportunity. I did that for a decade, and then became chairman of OBGYN at Long Island Jewish Medical Center. And right now I am professor of obstetrics and gynecology and women's health at Albert Einstein College of Medicine and vice president for women's health services of the North Shore Long Island Jewish Health System and chairman of obstetrics and gynecology at North Shore University Hospital and at Long Island Jewish Medical Center.
That's a rather impressive curriculum vitae for a relatively young person to move into that. During that time, when was your first exposure to the American College?
It was really through Marty Stone. My first year of fellowship was at New York Medical College, and Marty, of course, who was a past president of the college, was very active. And I think he really put me on the first committee that I was on, but I started to understand what the college did in some depth because of Marty when I was his fellow.
Now, you've been an active part of the college in many different areas. Could you explain to us a little bit some of the areas that you've seen the most value to you in your career in the college?
Well, I think people don't understand fully what the college does for them and how hard you and your staff and also the elected officers and district chairs and section chairs really work on behalf of all of our patients and on behalf of the fellows. The college, I think, means a lot to all of us in terms of what we do every single day. But on top of that, for me, it just was an amazing opportunity to grow. And I guess I was on the committee on professional personnel when I was still in training, and I started to get an understanding of how the college worked and what the college did. I was on a task force on breast disease very early in my career. One very exciting thing for me, and I think this was a combination of Harry Jonas and Warren Pierce, but I wound up I was put on CREOG, I guess, by Harry Jonas in 1986, and then in 1987 I became chair of CREOG and chaired CREOG for 6 years. And because of that, I went to all of the ACOG executive board meetings for 6 years and really understood what the college was doing. It was a very wonderful opportunity and really made so much difference in my entire career.
As the chair of CREOG, and obviously I knew you were chair of CREOG, what did you see were the major changes in education that took place during your tenure?
I think that the emphasis on OBGYNs as women's health physicians really evolved. I, of course, think that OBGYN is the best specialty and a very exciting way to spend our careers every single day. But I think there was an acknowledgement that not only do we provide specialty and subspecialty care in obstetrics, gynecology, GYN oncology, maternal fetal medicine, and so on, but that we really are, for a large subset of our patients, their only physician, their principal physician, the person who they come to for their healthcare needs, and we take ownership often of their preventive care needs and their screening. And I think there was a lot of evolution on the educational role that we as OBGYN educators play for our residents and for medical students as pertain to the primary care component, in addition to all the specialty and subspecialty care that we teach and do.
I believe you have edited at least 2 books and 1 journal in primary care. What do you see the future of primary care?
I think it doesn't matter whether we call ourselves primary care physicians or principal physicians. We are. I think for my entire career, even as a GYN oncologist, it was very impressive to me how little coordination there had been for the care of my patients other than what I was doing. And I think one of the reasons I began to put very heavy emphasis on primary care and on screening is because I realized that if we as OBGYNs were not doing it, our patients often were not getting that from anybody else.
You mentioned Dr. Pierce, Dr. Jonas, Dr. Stone. Were there other mentors in your career that you would see from ACOG who've been very helpful to you?
I've been overwhelmingly fortunate in that I always was excited about my career and what I wanted to do, but everybody was really wonderful. I think I highlighted 3 of the people who were very important to my career. But I guess I want to say something to any young person who is watching this tape, and that is that I think for the most part our specialty is very welcoming, and the people in our specialty really want to help to develop the careers of young people. So I think I would urge everybody to let people know what their dreams and goals are in the field, and there are always so many people who are generous with their time and really willing to help and willing to mentor people. And I think, certainly you were, in my role as president of the college, were the most magnificent mentor and really helped me to, I hope, do a very good job of being president.
I appreciate your saying that. We were talking just before we started the taping about a young person in your own program now who is moving in through the ranks. How would you say that you would identify young individuals, young OBGYNs that would have a future in the college?
For me as a program director, it was talking with my residents regularly, asking them when they came in, what do you think you want your career to be, making suggestions, and then at least twice a year we have very formal evaluation reviews where we meet officially with the residents to review their career paths and goals and how they're doing. And I think it's important for us as educators of residents to make sure that they understand what the opportunities are, understand what they need to do to go about becoming involved. And I think it's fine that not everybody chooses to be active in the organized medicine aspects of our specialty. I think everybody has to decide what it is that they want to do, but that we have a job which is to educate them about what's available. And then for those people who want to do things and who have the talent to do things, I think we really have to help them to get positioned and understand what they have to do to achieve these goals, and then help them by suggesting them for committees, suggesting them for opportunities.
You were the 48th president of the American College, but probably more importantly, you were the 2nd woman who was president of the college. What would you say would be the highlights of your presidential year?
I think every minute of it. It was all wonderful. For me, I think what we did on education about smoking and educating our fellows about educating their patients about smoking cessation, about not starting to smoke. I run into people all the time who tell me that they use the college's materials and that it made a big impact on how they practice and how they approach their patients. And of course the wonderful staff of people at the college who really did all of the work so that we could have these publications and have the programs that we have. But that was very exciting for me. And I think another thing was having my husband and my children and my parents involved at the ACM where I was inaugurated was very exciting for me.
Looking back on that year, now that you've had about 5 years to think about it, what would you do different, if anything?
I feel very proud of what happened during that year. I think nothing. What would you have had me do differently?
No, I wouldn't have you do anything, but I'd like to know how you feel about where we've gone and what you could have done, or could you have done anything different?
I think each president has brought a slightly different leaning and a slightly different flavor to the year when they were president, but the executive board, I was very fortunate. I had obviously great people who work for you at the college, a wonderful executive board who they were really easy to work with. I don't really think I would do anything differently. I think then after me, Jim Youngblood again brought his own direction. Each person who followed, I think, added so much, and we each built upon each other.
Do you think your year as president of the college has had a major impact upon your future career as you have now gone the last 5 years?
I guess because I learned so much. I learned a lot about how organized medicine can make major changes in the lives of all of the OBGYNs, and I think that has been a big help for me.
Well, let me take you to a little different understanding. Give me an idea. You served on the Residency Review Committee. You've been very active in resident education. What do you see as the future of our specialty?
I think our specialty, as I said a few moments ago, is the most wonderful way to spend your life. I think it is very exciting and very fulfilling. I think one of our main challenges now is to make certain that all of the medical students understand that despite the issues which we obviously face in terms of tort reform and some of the other challenges that we have, that it's still very wonderful to wake up in the morning or wake up in the middle of the night and know that OBGYN is what you're doing. So I think we have to make sure that medical students, all students, male and female, understand how wonderful our specialty is.
You mentioned male and female. Current statistics indicate that 73% of our residents are female. What do you see the impact of this large number of women entering our workforce be on our specialty?
Well, I think we need the largest talent pool possible, seeing what a great specialty obstetrics and gynecology is, so that I would hope that we reinvigorate men as well as women to see how great the practice of OBGYN is. I think ultimately what patients want is a doctor who's knowledgeable, empathetic, available, talented, and I don't think that those are gender-specific qualities. I think men are wonderful OBGYNs, as are women, and I would like to see the talent pool expanded and for both genders to think that this is a great specialty, which it is.
As indicated earlier, you were the second woman to become the president of the college, and we recently had a third. How long do you think it will be before this becomes rather common as opposed to just an anomaly?
I would hope within the next several years we will see as many female presidents as male presidents of the college. And I think when I was a resident, only 9% of practicing OBGYNs were women. Obviously, as there are more and more women, there are more women who are going to be excited to have leadership in the college. I happen to be particularly lucky. I had very supportive husband, parents who live close by, so I didn't have some of the logistical issues that maybe other women might have in terms of being able to balance my responsibilities.
Do you think the large number of women that will come into the specialty will change in any way the way we practice our specialty?
Again, I think that the qualities that make somebody a wonderful OBGYN are pretty gender neutral. So I think our specialty is changing, but I think that's just because some of the goals and life balancing issues of medical students are changing.
You mentioned early on as part of your career that you now are involved with this women's health group out at the North Shore Hospital there in Long Island. Tell me a little bit about how you see the evolution of these large women's directed healthcare groups.
Well, I run a women's health center, which is quite large. I think we have about 35,000 patient visits a year. I have a breast surgeon on staff, a cytopathologist who does the breast cyst aspiration analysis at the time of the procedure. We have a mammography facility, sonography, a psychiatrist. I think the women's health programs are wonderful. They are costly. We have a lot of philanthropy for our Women's Health Center, which enables us to do some of the things that are expensive to do and lose money. So I think one of the barriers in terms of having a multi-specialty group of people is that often because of the ancillary things that you do, it really is not financially feasible always without philanthropy to achieve what it is that you ideally would like to.
One of the things I think you told me some time ago was that there were about 16 hospitals in your system, or thereabouts?
We're growing every day. There are 9 obstetrical services, and we do 24,000 deliveries.
Now, with that large a group of hospitals that you have to deal with, what would you envision as the unique problems you've had to face?
I think I have the identical issue in my job as you do in your job, which is if you have talented people who are excited about what they're doing and good at what they do in each of the hospitals and in each of the programs, it makes it a lot easier. So I think something that I've been very fortunate is to have really quite talented, hardworking people. That probably is one of the most important things that I have to do.
One question which I get, and I know you always get, is that as a clinically trained oncologist who is used to taking care of women, how do you now reconcile that you're primarily in administration?
I do a little bit of patient care still for patients who I operated on in the past, and that is very fulfilling, and I look forward to my patient care days. I feel very proud of what our departments are doing and what our women's health programs are doing and what my junior colleagues and trainees are doing, so that I think it's just a different phase in the evolution of my own career, but an equally gratifying one.
Do you see this as a route that many of our younger physicians will ultimately take, or do you think that this just happens to be unique to someone like you that has the talents? There were great opportunities to have a large impact on a large number of patients, and it was kind of an irresistibly exciting opportunity. I'm not sure. I think you have to want to do it because probably it is not as minute-to-minute gratifying as taking care of a patient and having that great personal sense, an immediate sense of feeling great about the patient who you just took care of. For me, it's more of a looking back at the end of a day or a week or a month and thinking about the wonderful things that we've been able to accomplish because of the people in the system. Let me take you back to something you said a little earlier. You mentioned about the support you had from your husband and your parents. Do you think this is a unique support system and has essentially been something that allowed you to take this pathway, or do you think this is something that most women in medicine would be able to have?
Well, I'll tell you, I try to counsel my female residents to structure things so that they're living, especially those who become pregnant during residency or who are going to become pregnant early on in their first job, to try to move near family, to try to be in a situation where they have a good support system, because it's much more difficult. It's not impossible, but it certainly is much more difficult to have a very time-consuming and challenging career when you also have lots of logistical challenges at home. So I really would advise people to think about how to minimize the logistical challenges that they face. Recently there have been a number of studies that have been projected trying to determine alternative forms of practice. If I were a young OBGYN coming in to you for counseling today, how would you counsel me if I said, I really don't want to take night call? I am asked this, I think, by people who I train. I think you have to look at fundamental fairness. So I think for somebody who wants, I think it's wrong I think people regret it when they give up the breadth of the specialty too early. And what I advise people to do is, if you want a half-time job, do the entire breadth of OBGYN, but do it half-time. Take half the nights, half the weekends, and half the pay, but don't immediately leave a residency and limit your skills that you've just recently acquired. So I try to, and again, this does come up commonly because we're training so many women, I do try to counsel people to continue to practice the breadth of the specialty and to continue to take some amount of night and weekend call, even if it's a half-time position.
One of the things that in your role as an administrator at this point now, you have to be certain about coverage of the labor and delivery suites and the emergencies that come up. Some of our sister specialties have gone to a concept called the Hospitalist. Do you ever see OBGYN in this type of role where one person will be assigned to the hospital?
I think it's not impossible that we will evolve to the hospitalist model, because it's in our own hospitals. It seems to work extremely well in internal medicine. I do think that the physician gives up something by stopping, especially in obstetrics. I think abandoning prematurely the continuation of what you love to do and what you've been trained to do, that is obstetrics and the GYN surgery, and just having an office model of practice, from the doctor's point of view, is giving something up. And I think for patients, they do like it if they have the same doctor who takes care of them for all problems, both in and out of the hospital. But my suspicion is that the logistics of a hospitalist model really are a lot easier, and that we may go in that direction. Again, it works very well in my hospitals in internal medicine. I sort of regret that I think that's where we may be going, but I do think it's where we may be going.
One of the things that we've seen in some of the specialties of medicine now is much more fragmentation and branching. We're now seeing in OBGYN, besides our standard 3 subspecialty areas, the 4th specialty of urogynecology. And as I recall, during your presidential year, this was a very hot topic, very highly debated. How do you feel now, 5 years later, that you look at this evolution?
I'm glad I don't remember what I thought then, but I do know what I am seeing now. I think that just as GYN oncology improved the care that women received, I think that the subspecialty of urogynecology and pelvic reconstructive surgery really is making access to care, and very sophisticated and talented care, more available to women. So I think that this evolution actually, from what I see in my own hospitals, is extremely positive for women's health, and I think we're doing a lot for our patients by this evolution.
But do you think the fact that we have now become so subspecialized that we are now taken away from the beauty of being a generalist OBGYN?
I think there are still opportunities for people to practice as a generalist OBGYN, depending on which part of the country you practice. And I think when people come out of training, they're able to do the breadth of the specialty. So if you go to a hospital where there's a urogynecologist and a GYN oncologist and a maternal fetal medicine group, you're probably going to do less of that. But if you go somewhere where you are required to step up to the plate and be able to practice more of the breadth and depth of the specialty, that people do that. So I think deciding where to take that first job probably affects the spectrum of your own practice over time.
Well, when you were on the residency review committee, this issue came up, the issue of expanding the training program by 1 year, or allowing the resident to make a choice in that last year of training based upon what type of practice they were going into. Now that you have a chance to see the practitioners, to see the trainees, do you think we really should be readjusting our training schedules to allow the residents to have a, as we say, kind of an a la carte 4th year?
I do think it's important that we don't fragment our specialty, so that I think the first, in my mind, a really key issue is that everybody who practices, whether it's maternal fetal medicine or gynecology or urogynecology and pelvic reconstructive surgery or a generalist, that everybody feels that they are an obstetrician, gynecologist providing women's health care, and that there is a lot of concordance among all the different people in subspecialties regarding the fact that first and foremost they are OBGYN women's health physicians, and that they also are subspecialists in their particular subspecialty. So I'd hate to see our specialty become too fragmented.
Now that the college is 5 years beyond where you are, we're involved in a lot of political activities and things. If you could, in one decision, decide the direction of the college different from where we are now, where do you think the college should be going?
I was very heartened this morning to see how much emphasis there is on our current professional liability reform issues. I think that the college is where it should be, and I think that's where it needs to be concentrating its efforts, because I think it is terrible for our patients and for our fellows that women will be denied access to care, and people who have spent decades preparing to be an OBGYN and then practicing OBGYN will have to deny their patients the care and deny themselves the opportunity to continue to practice something that they love to do. So I don't think the college should do anything different. I think that you have identified some of the most important things to women and to OBGYNs right now, and I know you'll be successful in addressing these issues.
One of the issues that always comes up in the college is about growth of membership, and should we be restrictive in terms of requiring board-certified members before we let them, board certification before we allow them to become members. What do you think about loosening and bringing in all health care of women providers?
I think the college has always focused on education of people providing health care to women on issues of access. I think by having the subcategories of membership that we have, we really are continuing to enhance the numbers of people who have access to that education and advocacy. On the other hand, I think there is something very special and very important about being a board-certified obstetrician gynecologist, and I think that to be a fellow of the college, my opinion is, should still require that you're a board-certified OBGYN.
One thing that the future will hold for us, we know already, although we don't know how long it'll take for it to come into being, is competency evaluation. As a person in a position such as you, where you have to literally evaluate the competency of all the people at all your hospitals, how do you see this impacting upon medicine and the care of patients?
It is a complicated process, and as you know, we are now trying to have very official ways to evaluate competency, measurable and clearly definable ways to evaluate competency for our residents, and also as we do our reappointments, which I'm in the process of doing now, evaluating the competency of the attending physicians, the PAs, and so on, who have privileges. It is somewhat complicated. For me, it's easier because I have division directors who are able to evaluate the competency of their colleagues as they work during the course of the year in OB and in GYN. And Dr. Kaufman, who's our assistant program director at LIJ, and Mark Spitzer at North Shore. So I have very hardworking, talented people who are doing these assessments, but it is complex. Sometimes the assessment is really the absence of problems, looking at the numerator of patients for whom you've provided care, and as the denominator, and the numerator being, for the attendings, the numbers of times that there have been any problems. That probably is not the ideal. Absence of problems is probably not an ideal way to evaluate competency.
Well, Dr. Seltzer, I want to thank you very much for your willingness to come and share your ideas with us, and most important, to share a little bit about your experience with the college, where we are today, where we were when you were president, and where we will be in the future. It's been a real pleasure to talk with you.
Well, it's been my privilege.